Hi all, welcome back to the platform on for AOL YouTube channel. I'm Dr. Dinsha from the Department of Oral Pathology. Today we are going to have a discussion on the topic odontogenic cyst. So, yeah, I hope the screen is visible to you all. So let's learn about what is odontogenic cyst and what are the lesions coming under that. So basically, what is a cyst? The cyst means any kind of a pathological cavity. It may or may not be lined by an epithelium and which usually contains a fluid or a semi-fluid or a gaseous material and usually not created by accumulation of pus. So this definition has been given by Kramer in the year 1974. So basically the cyst can be in any location in the oral cavity. It can be lateral to a tooth, or it can be in the periapical region, or it can be associated with an unerupted or an impacted tooth. So basically, we have three parts for a cyst. So if we divide the cyst into three parts, we have the fluid-filled area of the cyst. We call it as a cystic cavity. And the cyst, which have been lined by epithelium, you can see a thin cystic lining or an epithelial lining. And of course, it will also have a connective tissue component. So we can just look at an example of this half-cut bowl. So this would be the lumen or the cystic cavity. Then there is an epithelium and there is a connective tissue area. So these are the three components of a cyst: lumen, epithelial lining, a wall or a capsule or a connective tissue. Now we shall see the classification of this odontogenic cyst. The cyst of the oral region has been classified into epithelial lined and non-epithelial lined. Under epithelial lined, we have the developmental cyst and an inflammatory cyst. Under developmental, we have odontogenic cyst, that is those cysts which are arising from the odontogenic apparatus, and we have non-odontogenic cyst also. So the classification of this cyst has been given by World Health Organization, and it has been latest updation has happened in the year 2017. Previously, it was in the year 2005. So after 2005, the updation happened in the year 2017, and they have made some changes in the classification. So basically, we have I'm only talking about the odontogenic cyst here. So under odontogenic, we have developmental and the inflammatory cyst. Under developmental, the cysts coming under that are dentigerous cyst, lateral periodontal cyst, and botryoid odontogenic cyst, glandular odontogenic cyst, gingival cyst, odontogenic orthokeratinized odontogenic cyst, odontogenic keratocyst, and calcifying odontogenic cyst. Under inflammatory, we have radicular or periapical cyst and inflammatory collateral cyst. First one is a dentigerous cyst. So dentigerous cyst is also known as a follicular cyst. So this cyst usually surrounds the crown of an impacted or an unerupted tooth. So what happens is when a tooth is erupting, usually between the enamel surface, the enamel surface is being covered by a layer of the reduced enamel epithelium. So between these area, that is between the enamel surface and this reduced enamel epithelium, there would be the accumulation of the fluid, which is causing the formation of this dentigerous cyst. And most common type of odontogenic cyst is dentigerous cyst. So this is how it would be. So this is an unerupted tooth, and there is a cavity or a cystic lining have been formed, and there is fluid accumulation at this area, that is between this enamel surface and the reduced enamel epithelium. Most commonly seen in maxillary and mandibular third molars, followed by maxillary cuspid, more in second or third decade with male predominance, and usually it would be solitary in nature. We would usually see one dentigerous cyst, but there are situations wherein you can see multiple cysts in an oral cavity. Usually it has been associated with some syndromes. So there are two syndromes given here. In these conditions, there can be the presence of multiple or dentigerous cysts. Those are the Martok-Salami syndrome and cleidocranial dysplasia, wherein you can see multiple odontogenic cysts. And clinical features would be patient will usually have pain, and there is expansion of the bone with facial asymmetry, displacement of the teeth, and severe root resorption of the adjacent tooth. Radiographically, it appears like you can see a radiolucent area surrounded by this unerupted tooth. So we have some radiological variants in this dentigerous cyst. Those are the radiolucency surrounding the impacted tooth in a central manner, you call it as a central type, where if it is extending towards the lateral side, you call it as a lateral type, whereas in the last picture you can see it is completely covering the unerupted tooth, you call it as a circumferential type. So the three radiological variants are central, lateral and circumferential. Then a little bit about the follicular space. So follicular space is a space which is being seen in the crown of an unerupted tooth. So this crown of an unerupted tooth is being covered or surrounded by the structures or the cells known as the dental follicles. The dental follicle is nothing but a soft tissue remnant of our enamel organ or the reduced enamel epithelium. So you can see in this picture, this is a tooth, the crown of a tooth, and you can see a radiolucency which is covering this, which is completely a normal thing. And this dental follicle usually comprised of dense fibrous collagenous tissue and some nest or cords of odontogenic epithelium also you can see. And usually the distance of this follicular space is considered as 2 to 3 mm, which is a normal space. But in case, you can see, look at this picture. Here there is a normal space of radiolucency or a follicular space of 2 to 3 millimeter, whereas here the space has been increased to 2 to 4 millimeters, whereas here you can see again it has been extended more and the dimension has gone to more than 4 millimeters. So only at this case, when it is increased more than 2 to 3 mm, we need to consider thinking of a cyst. And it is mentioned that if the follicular space is more than 5 mm, only then we can consider it as a dentigerous cyst. Next thing is the histology or histopathology of the cyst. So, under the histopathology, a dentigerous cyst appears to have a very thin layer of stratified squamous epithelium. You can see a thin layer of stratified squamous epithelium with a very loose connective tissue with some areas of odontogenic epithelial islands also we can visualize in the connective tissue. And in the epithelium, there could be some inflammatory infiltrate with presence of some hyaline or eosinophilic bodies. You call them as Rushton bodies. So these are those linear or even curved hyaline bodies of uncertain origin, and you call them as the Rushton bodies. And in the connective tissue, you can also see some areas with some basophilic calcification and peripheral bond formation. Treatment for dentigerous cyst is surgical removal or mastophilization. An untreated cyst can have a complication of it can develop to ameloblastoma or an epidermoid carcinoma or mucoepidermoid carcinoma. So to conclude, dentigerous cyst is considered as the most common odontogenic cyst with a follicular space more than 5 mm and with a predilection in the males. Syndromes associated, that is in the multiple cases, when there is a multiple dentigerous cyst, we have the syndromes which have been associated with that. And radiographically, we have three types: central, lateral, and the circumferential. And under histopathology, you see stratified squamous epithelium with loose connective tissue with islands of odontogenic epithelium in that. And complications are it can develop to ameloblastoma, SCC, or mucoepidermoid carcinoma. Next is coming under the list is the eruption cyst, which is also known as the eruption hematoma because it clinically has a purple or a bluish hue appearance. So this has been added under the dentigerous cyst in 2017 classification. So in 2005, it was a separate cyst, and in 2017, it has been added under dentigerous cyst, considering that this is a dentigerous cyst which is happening in a soft tissue. So it has been added under the category. And more commonly, you see in children, both in deciduous as well as in the permanent dentition, more towards in the anterior to first molar, and usually the tooth is embedded in the soft tissue of the gingiva. So as you can see in the picture, it appears to be like a soft translucent swelling in the gingiva overlying the crown of an erupting deciduous or a permanent tooth, usually aged less than 10 years, and radiographically a mild soft tissue shadow can be seen, nothing much. And histopathologically, it shows normal surface or oral epithelium with inflamed connective tissue. As such, there is no treatment required for this condition because this cyst will rupture as its own when the tooth start erupting into the area, or sometimes a simple excision would be needed. Next cyst is the lateral periodontal cyst. So as the name says, it presents lateral to the tooth surface. This is a very small, non-expansile odontogenic cyst, originates from the remnants of dental lamina. And this cyst arises in intimate association with the lateral root surface of an unerupted tooth. More common location is the mandibular bicuspids or mandibular premolars. So you can see in the picture, it is associated with the lateral surface of the tooth. Radiographically, it appears like a small radiolucency, which is rarely over 1 centimeter and may or may not be well circumscribed with an opaque margin. Whereas, if it has been appearing like a polycystic variant, that is, this is a single cyst or a unicystic variant here, but if you see more radiolucency or a polycystic variant or a multilocular variant of the same lateral periodontal cyst is seen in the lateral surface of the tooth, you call it as a botryoid or odontogenic cyst. That means a polycystic or a multilocular pattern of your lateral periodontal cyst is known as a botryoid odontogenic cyst or BOC. The botryoid meaning the bunch of grapes. This also originates from the rest of dental lamina cells. So this is how it appears, a cluster of grape-like appearance. And again, common location is the mandibular bicuspids. You can see the radiolucency and you can see here some multicystic variants. This is also more common in the adult and again males, more in mandibular canines, bicuspids or incisors. Radiographically, a radiolucent lesion which is more than 1 centimeter present on the lateral surface, mostly in the multilocular appearances. Histologically, you can see a thin, non-keratinized epithelium of 1 to 5 cell layers thickness, resemble like your reduced enamel epithelium. And over the basal area, you can also see cuboidal or the columnar cells. Some of the cells will be clear with vacuolated or glycogen-rich cytoplasm can be seen. And in the capsule, you can also see the rest of the dental laminas. Treatment again is a surgical enucleation, and BOC, since it's multicystic, it is shown to have an increased risk of recurrence. So a periodic follow-up is mandatory for these lesions. Next one is known as a GOC or glandular odontogenic cyst, which is also known as a odontogenic cyst. This is considerably a large, a solitary or a multilocular odontogenic cyst, again derived from the rest of dental lamina. You will have a lining of stratified squamous epithelium, but it is glandular odontogenic cyst. No? So as the name says, it will have more of glandular cells or a mucus secreting cells can be seen over the epithelium. Radiographically, you would see a well-defined multilocular radiolucent appearances. A wide age range group is there around 10 to 90 years, more in males again, which are slowly progressive, painless, and locally destructive lesions, more commonly seen in mandible. Histopathologically, you would see a non-keratinized stratified squamous epithelium of varying thickness, and you can also see in the epithelium there is the presence of glandular or pseudoglandular structures and which has the capacity to produce mucus. Treatment is again conservative surgical management with dissection of the margins. Next cyst is known as a COC or a calcifying odontogenic cyst, which is also referred as a Gowland cyst or keratinizing or calcifying epithelial odontogenic cyst. This is considered as a very rare, well circumscribed, a solid or a cystic lesion which is derived from the odontogenic epithelium and which usually contains a ghost cells and spherical calcifications. And there are similar lesions seen over the skin which are referred as the calcifying epithelia of Malherbe, and this COC usually shares a similar histopathological features of craniopharyngioma. So the cystic condition is called as the calcifying odontogenic cyst, and the benign condition of the same is called as a dendinogenic ghost cell tumor. So in the previous or in 2005 classification, they have added calcifying cystic odontogenic cyst that has been removed. Now we have only one cystic variant and the benign variant is dentinogenic ghost cell tumor. This again seen more commonly in the second or third decade in the anterior jaw, and it has two variants. One is in the central, another one is in the peripheral. Central variants are usually asymptomatic, slowly growing, hard swelling with bony expansion, whereas peripheral ones are usually a sessile or a pedunculated lesion with smooth surface. Radiographically, initially the lesion appears like either a unilocular or a multilocular appearance, which is completely radiolucent initially. As and when the lesion progresses, you can see there are mixed areas of lucent and opaque areas. And as and when it matures more, you see more of radio opaque areas. Histopathologically, you would see a lining with odontogenic epithelium, and proliferating odontogenic epithelium will be forming follicles and they are projected into the underlying connective tissue. So you can see these epithelium which are being projected into the underlying capsules. And there would be areas of so-called the ghost cells. So these are the ghost cells. These are some irregularly placed or irregular outline with eosinophilic cells, and you don't see a proper nuclear structure also. So these kinds of cells with highly eosinophilic, larger in size and irregular outline, you call them as a ghost cell. And some of these ghost cell with time it will undergo calcifications also. So you would also see calcifications within the capsule. Treatment again is enucleation of the cyst. Next one is the gingival cyst. So gingival cyst is an uncommon, small, extra-osseous developmental cyst of the gingiva, originates from the rest of dental lamina. More commonly seen in fourth decade and in the mandibular canine or a premolar location. Clinically, it is painless, small, sessile with soft tissue swelling, common in the interdental area of attached gingiva, often appears to have a bluish or a blue-gray hue. So this is how it appears. Radiographically, gingival cyst does not show much of the radiographic evidence of bone resorption. And histologically, we can see a thin lining of epithelium resemble like the reduced enamel epithelium, identical to the lateral periodontal cyst-like appearance would be there. Under the whole capsule, you can see some small nest of glycogen-rich clear cells, and dental lamina rest cells also can be seen within the connective tissue. So the gingival cyst of newborn can also be called as Epstein pearls or Bonn's nodules. So these are some small multiple whitish papules seen over the mucosa or over the alveolar process of the neonates. They are very small with a diameter of 2 to 3 millimeters and more commonly in the maxillary region. And under the histopathologically, you see a very thin flat epithelial lining with parakeratinization, and it would contain keratin debris. So this is how the Bonn's nodules would appear. You can see in the alveolar region here. So these are considered as the remnants of salivary glands which are located buccal or lingual to the mucosa, and they are filled with the keratin and they are scattered over the palate along the junction of hard and soft palate, also in the alveolar region. Origin is considered to be from the palatal salivary gland structures. These are the Epstein pearls. Those are the cystic keratin-filled nodules seen over the mid-palatine of the neonates. Again, it arises from the remnants of the epithelial cells from the mid-palatine raphe. Histopathologically, these are considered as true cysts with thin epithelial lining. Lumen will have the desquamated keratin debris, and there can be presence of dystrophic calcifications, hyaline bodies, and Russian bodies, and as such, no treatment is required for this condition. Next, we have is odontogenic keratocyst or OKC. So, in the 2005 classification, this OKC was not actually under the cyst. It was under the odontogenic tumors classification, and it was named as keratocystic odontogenic tumors, considering its few features and its aggressive nature and few molecular or the genetic changes or genetic mutation which was favoring towards for a tumor. Whereas in 2017, it has again come back to the cystic classification and it is now called as OKC. And the term OKC was coined by Philipson in the year 1956. And the characteristic features of this lesion was described by Pinborg and Hansen in the year 1963. So according to WHO, it's a benign uni or a multicystic intraosseous tumor of odontogenic origin. That is in the earlier classification, it was considered as an odontogenic tumor with stratified squamous epithelial lining for an